So good evening, everyone. Today we have a very special session by Dr. Suchitha. She is from Anesthesia Department in RML Hospital, Delhi, and she'll be taking something on Pediatric Airways. So I'll give it over to her now.
Okay, thank you, sir. Hello, everyone. This is Dr. Suchitha Kuntla. I'm a third year anesthesiology resident at RML Delhi. We'll have a short session on pediatric airways today. So, to begin with, pediatric population is not just miniature adults. They're very different anatomically, physiologically. It is more important for an airway manager to know that they're very different anatomically. Physiologically, in terms of respiration, they have got poorly supported and compliant airways. They have got the airways understandably are of a smaller diameter, hence have a high resistance, and a highly compliant chest wall, which makes it difficult for them to generate the negative intrapleural pressure or generate adequate transpulmonary pressure for any event of respiration. And they also have got higher metabolic rates, for which their work of breathing is usually higher, around three times that of adults. They also tend to get early fatigue or apneic, since their diaphragmatic muscles and intercostal muscles are not the type 1 skeletal muscles like in adults, which usually the transformation occurs over 2 years of age. And they are the usual population you encounter with syndromic and genetic conditions. So their airway, dealing with a pediatric airway, needs some amount of understanding. So throughout this session, the plan is not to dump all the information about how different their airway is. Instead, I'd want to discuss it in starting with the nose, with the oral cavity, and going further distally, how it is different at every part of the airway, and what are the clinical implications of it, and how can you better your practice with respect to your differences that you understand. To begin with, pediatric population, they have a proportionally larger head. The occiput is relatively large compared to the body size. So
Suchitha,
when
excuse me.
you,
Can you?
yes, sir.
Actually, the screen is not moving, so I think maybe you can put it into full screen or something.
Yeah, it is in full screen. It is in full screen, sir. It's in presentation mode.
Actually, it is not really moving here.
Okay. Can you see the second slide now?
Now I can see the second slide.
Okay. Can you see the second slide now, sir?
Yeah, I can see the second slide now.
Okay. Okay. So, understandably, the pediatric population they have got a larger occiput. So, when they lie supine, the neck is usually in a flexion state. So, there is a potential airway obstruction when they are lying supine. So, to maintain the airway patency, it is always recommended to attain a sniffing position, for which the plan is to usually go for a shoulder roll. When using a shoulder roll and attaining a proper sniffing position, the goal is to get your external auditory meatus and the suprasternal notch in the same horizontal plane. While doing that, you also need to ensure that the glabella and the chin are in the same horizontal plane. Also, you need to ensure that the front of the neck is wide and open. You need to understand that using a shoulder roll alone does not give you a proper sniffing position. Along with that, you might need a headrest. Can you see the next slide now, sir?
Not yet, actually. I think you'll need to exit full screen mode. I think that is issue.
Okay.
Now it's
Okay. Okay.
visible.
Okay. 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 So in the first image, as you can see, using a shoulder roll alone, the end goal points are not really horizontally aligned, but the anterior neck space is wide open. And in the second image, as you can see, using a shoulder roll alone again doesn't help you align your points in a horizontal plane. So usually, using a shoulder roll alone tends to hyperextend the head, and a balancing headrest is usually necessary. And if you see this image, they haven't used either a shoulder roll nor a headrest. A simple extension has aligned the external auditory meatus in the suprasternal notch, and your chin and a glabella in the same horizontal plane, and the front of the neck is wide open. So all you got to do is decide as to what your patient needs. But in emergencies, usually you don't get the time, but you have got the time to assess and decide. Please plan on what your patient needs and customize so as to maintain a patent airway. Coming to the routinely used airway maneuvers with respect to pediatric population, as you can see, the head tilt and chin lift maneuver, performing that in an infant and in a child, is different with respect to the end goal you attain. A pre-maneuver, the infant when lying supine, the neck is in a flexed position. But in a child, it's in neutral position. Performing a head tilt and chin lift in an infant, you need to achieve a neutral position, while in a adult or a child, what you achieve is the sniffing position. When you fail to relieve the airway obstruction by chin lift and head tilt maneuver, what you go for next is a jaw thrust, where you use your fingers to gently lift the mandible upward and outward without altering the position of the head. This maneuver comes in very handy, especially when dealing with injuries of C-spine and injuries of C-spine. So, while if you're dealing with some kind of pediatric trauma, placing the heels of your hand on the sides of the forehead can actually help in stabilizing the position of the head. So, after you have dealt with the airway maneuvers, let's start with the nose. So, how is a pediatric nose different from adult? So, the nose, it is soft and distensible. It has got more mucosa and lymphoid tissue. Traditionally, we were taught that a pediatric population is belong to obligate nasal breathers up to 3 to 6 months of age. But lately, it has been the teaching has changed to the fact that they're preferential nasal breathers, in the sense that in cases of trauma or in cases of active ongoing bleeding epistaxis, they can actually tolerate nasal packing. So they are not actually obligate nasal breathers. Instead, they are preferential nasal breathers. But one can notice that any kind of nasal secretions, edema, blood, or foreign bodies within the nasal cavity increases the work of breathing. For the same reason, neonates are given oral riles over nasal riles, especially when it is planned to be left in situ for longer duration. And while performing any kind of instrumentation through the nasal cavity, you might actually encounter hypertrophied inferior turbinates and choanal atrasias. And this might also make it difficult for you to perform a nasotracheal intubation. Paranasal sinuses, as such, you don't have much to do with it when it comes to managing the airway, but I've just thought of mentioning it so that one doesn't fret looking at a neonate's skull X-ray. So at the time of birth, only maxillary and ethmoidal sinuses are present, and they grow rapidly through the first 2 years of life. Maxillary is seen on the radiographs by 2 to 3 months of age. The frontal and sphenoidal develop later in the life. Frontal shows greatest degree of developmental variation in terms of pneumatization of the sinus. It is radiologically seen by 5 to 6 years of age, and sphenoidal sinus, the pneumatization is done by 2 years of age, and it is seen radiographically by 1 to 2 years of age. The next structure that we're going to encounter as you go distally is a nasopharynx. The important structure that you encounter that might trouble your airway management is a hypertrophied adenoid, a nasopharyngeal tonsil. In this X-ray lateral view, you can see the hypertrophied adenoid, and on nasal endoscopy, this is the posterior pharyngeal wall in the nasopharynx. You can see adenoid hypertrophy. There is a risk of dislodgement of the tonsil or even bleeding, uh, bleeding around the friable mucosa around the tonsil while performing any kind of instrumentation, something as trivial as a Ryle's tube insertion. Next comes the oropharynx. In pediatric population, the oropharynx is an area of interest. It extends from soft palate to the tip of the epiglottis. You might encounter enlarged palatal tonsils here and masseter spasm in response to an active tonsillitis, which can actually make it difficult passing the tube. And the pediatric population differs very much from adults in the fact that the tongue is large in comparison to the oropharynx, and any amount of mild sedation or depressed consciousness of the child can result in airway obstruction. One need to understand that head extension alone doesn't lift the tongue off of the soft palate or the posterior pharyngeal wall. What it does is it increases the hypopharyngeal patency by the anterior motion of the cervical spine. This holds true in pediatric population and in adult population. So, head extension during positive pressure ventilation is recommended in neonatal resuscitation protocol and neonatal life support algorithm, but none of them mentions how much of head extension will result in an patent airway. People at John Hopkins have thought about the same. So they have conducted a retrospective study where they have examined sagittal MRI images to understand airway patency and to understand the relationship between airway patency and angle of head extension. The angle is measured from occiput to C7 cervical spine. So they have excluded the patients with artificial airways or distorted airways from surgeries or congenital anomalies. So they were left with 63 children, which is not very much. It's not a very high powered study. But still, it provides us some evidence as to what angle of extension will help you maintain airway patency. As you can see here, the airway is patent in the first image, it is not in the second image. So they concluded that there is at least a 95% probability that the airway would be patent if you maintain a head tilt of something between 144 to 150 degrees. The median head tilt angle that was associated with an open airway in newborns and infants was found to be 125 degrees. And to maintain airway patency, we tend to extend the neck, but hyperextension can actually worsen the obstruction by by the movement of tongue and palatal soft tissue due to the effect of gravity onto the posterior pharyngeal wall. So you neither hyperextend nor extend it to a lesser angle. Optimal would be something around 125 degrees. So while we talk about maintaining airway patency, I would like to discuss a few airway adjuncts. First comes the nasopharyngeal airway. The goal of placing a nasopharyngeal airway is to maintain airway patency and by lifting the tongue off of the posterior pharyngeal wall. So in placing a nasopharyngeal airway, the length of the airway is important than the size of the airway. How do I measure the length of the airway? You usually go from a lateral aspect of the nose to the tragus of the ear on the same side. A nasopharyngeal airway that is too long is uncomfortable for the patient, can actually instigate a gag reflex. The patient might even end up regurgitating liquids or fluids. And the one that is too short serves no purpose because the airway obstruction is not going to be relieved. While coming to the size of the nasopharyngeal airway, it the usually you choose the one that corresponds to patient's nostril size. The internal diameter must correspond to the patient's nostril size. But as the manufacturer changes the outer diameter and the material used changes, the outer diameter of the airway changes, which can actually cause mucosal injury when left in situ for longer duration. So please ensure that it is not cause blanching of the tissue of the nostril when you're leaving it in situ. And understandably, nasopharyngeal airways are better tolerated than oropharyngeal airways. You'll actually see patients and kids with nasopharyngeal airways left in situ in your plastics and ENT wards all the time. There are certain contraindications for using a nasopharyngeal airway, as in bleeding disorders, nasal or cranial trauma, newborns with septal deviation, nasal polyps, and any kind of craniofacial abnormality that you don't completely understand. Next comes the oropharyngeal airway. After a failed jaw thrust, you go for oropharyngeal airway to maintain a patent airway. This is especially tolerated well in an obtended patient with obtended airway reflexes. So the common oropharyngeal airways you get to see are Goodell's and Berman's. I'm sure everyone has seen a Goodell's. So traditionally, it was taught that the right size of an oropharyngeal airway is from the angle of mouth to angle of mandible. But recent studies found that an oropharyngeal airway measured this way always falls short and doesn't actually relieve obstruction optimally. So the current recommendation is to measure the oropharyngeal airway from central incisors to the angle of the mandible when laid on the face with the concave side up. The insertion technique is also different in pediatrics as compared to adults. Again, due to the fact that they have got a larger tongue in comparison to the oropharyngeal cavity. In age greater than 8 years, it is to be inserted just the way you do it in adults, with the concave side up, pass to the back of the hard palate, and then rotate by 180 degrees to turn the concave side down. But in less than 8 years, it is recommended to insert an oropharyngeal airway under direct vision using a tongue depressor with the concave side down and congruent with the tongue. Next comes the laryngopharynx. It extends from the tip of the epiglottis to the lower border of the cricoid cartilage. The larynx, it bulges into the center of the laryngopharynx, leaving two recesses on the either side, known as the piriform fossa. This is a common site for foreign body impaction, especially the sharp ones. The most common one that presents to emergency is a fishbone. Next comes distal is the structure of interest, which is epiglottis. So, epiglottis in pediatric population is defined to be long, stiff, omega shaped, or U shaped. Some describe it as stiff, some describe it as floppy epiglottis, but anyone who has dealt with an airway, pediatric airway, know that it's a stiff epiglottis in pediatric population always. And it projects posteriorly over the glottis at 45 degrees. It is obliquely angled, and it makes it difficult visualizing the chords. So the larger tongue, the epiglottis with this weird shape, makes it all difficult for us to understand as to what laryngoscopy blade am I to use. Is it a straight blade? Is it a curved blade? So before entering that debate, let us understand that we have got few straight blades, few curved blades. The most common straight blade we are aware of is Miller's, and curved is McIntosh. We have got other straight blades, the Phillips and Wisconsin, and curved Kessels and McCoy. Mind you, they don't make McCoy in pediatric sizes. So why do we always get confused between the fact that do I go for a straight blade or a curved blade? The usage of these blades, it doesn't just have anatomical and success rate of intubation impacts, but they have got physiological and laryngoscopy responses that are different from each other. So over the years, after studying in multiple groups of pediatric populations, they have come to a conclusion that the success rate of intubation between curved and straight blades in children younger than 2 years old is the same. So many clinicians, they prefer to use a straight blade out of practice, but it because they feel it is a superior in elevating the base of the tongue and visualize the larynx as compared to a curved blade. We'll see why. But the success rate of intubation is the same with both of the blades. How is the laryngoscopy response that these both elicit is different? Is based on the fact that using a Miller's blade, you're directly visualizing the glottis by lifting the epiglottis from its inferior surface. The inferior surface of the epiglottis is densely innervated with the recurrent laryngeal nerve, the sensory afferents, and performing a laryngoscopy using Miller's straight blade by lifting the epiglottis from its inferior surface. It instigates a very strong vagal stimulus, vagal reflex. The patient might actually have a severe bradycardia and hypotension. And in contrast to that, a Macintosh plate, you place it in the vallecula where you press on the median glossoepiglottic fold beneath which lies your hyoepiglottic ligament, and you're lifting the epiglottis indirectly. The vallecula is innervated by the glossopharyngeal nerve, so you're not instigating any kind of vagal reflex. So the choice of blade you make is not just dependent on the population you encounter, but also the patient factors. As opposed to, let's say you have got a patient with a C-spine injury in a real bad neurogenic shock with already pre-existing bradycardia, hypotension, and you plan on intubating the patient, and you choose a Miller's blade. So you might actually worsen patient's hemodynamics with the choice of blade you choose. So it's important to understand that it's not just anatomical but also the physiological differences with your airway choices. These are the sizes of laryngoscopy blades recommended. For preterms, we go for a 00 or 0. For neonate, a 0. Infant, 1. And later on, you can please refer to the table. It is also recommended to perform a very gentle laryngoscopy, and it's not an adult larynx. Please do not use your shoulder muscles to lift the epiglottis. Please perform it very gently. The way you hold the blade is also different while performing a. The way you insert and the way you hold the blade also needs to be very gentle. You might actually end up fracturing the laryngeal cartilages. Avoid inserting the blade too deep into the esophagus and then withdrawing to visualize the larynx. This can actually cause trauma while you withdraw it, scraping the mucosa and the arytenoids. So the usual standard approach using either a curved blade or a straight blade is to insert it from the right angle of the mouth and then push the tongue to the left and into the submandibular space so as to clear the oropharynx and improve your glottic view. But there are a few other approaches where in situations with a retrognathia or mandibular hypoplasia or in cases of trauma where you can perform a paraglossal or retromolar intubations. This is more of a hands-on thing to understand, but you can definitely read up on that. The laryngeal manipulation techniques, they remain the same for pediatric population just like adult population. So one thing I recommend people performing any kind of airway management is to use both your hands. You save a lot of time actually performing bimanual laryngoscopy as opposed to communicating with your assistant to give burp. Burp is not very practical. So, what do you mean by bimanual laryngoscopy? This all stems from the concept of optimal external laryngeal manipulation. So, the person standing at the airway performing the laryngoscopy uses both of his hands. Most of the laryngoscopes are designed for left handed use. So, you perform laryngoscopy with your left hand while you use your right hand to manipulate your larynx externally by identifying the thyroid cartilage, as you can do it by an Adam's apple, by palpating for the Adam's apple. In pediatric population, even though it's not very prominent, you still need to be able to appreciate it and manipulate the larynx at your comfort so as to quickly improve your glottic view and quickly perform intubation. The goal is to always limit the duration of laryngoscopy, and that's bimanual laryngoscopy. Modified bimanual laryngoscopy is when you take your assistant's hand, with consent of course, and put it on the patient's thyroid cartilage and use their hand to manipulate the larynx and achieve a proper glottic view and ask them to maintain that level of manipulation and quickly intubate the patient. You actually save a lot of time, and burp is not a standard practice. What is practiced now is optimal external laryngeal manipulation. And the CL grade remains the same for pediatric population as it is for adults. Next comes larynx. The larynx in pediatric population is more rostral or cephalodly located. It is very close to the base of the tongue as opposed to adults. And even though it is thought that it is anteriorly located, it's not. It's actually not. So as the human grows, the cricoid goes down, descends a few cervical levels. At birth, it is usually C3 to it is at C3 to C4 level. By 6 years of age, it reaches C5, and in an adult, the cricoid cartilage lies at corresponds to C6 vertebral level. Cricoid is the most common landmark used for identifying the C6 level and then perform a lot of nerve blocks. So embryologically, the larynx it develops from the ventral wall of the foregut, and definite larynx is identified by 41 days of gestation. The primitive glottis is formed at 10 weeks of gestation. The true vocal cord split, and failure to split is what results in a laryngeal web and congenital atresia of the larynx. The cricoid cartilage, understandably, is very small in children. It's a complete ring, and the presence of mucosal edema at this site will severely compromise the airway. So, in larger airways, the flow of air is usually turbulent. In smaller airways, it's laminar. So, as you can see here, any amount of edema, let's say the patient develops 1 millimeter of edema, the same 1 millimeter of edema in infant and in the adult. When the flow is turbulent, the resistance is inversely proportional to radius to the power 5. But in adults it's a proportion, I mean, sorry, in situations of laminar flow, the resistance is inversely proportional to radius to the power 4. So in infants with edema as minimal as 1 millimeter, you can see the resistance in the larger airways increases by 32 times, while it increases by 5 times in an adult. So the work of breathing increases proportionately, which is very high for the infant. The goal is to always limit airway edema. Uh, and Because of the smaller size of the cricoid, they are at risk of acquired subglottic stenosis with prolonged and repeated tracheal intubations. So the last line, the fear of subglottic stenosis has historically limited airway managers from using cuffed tubes in pediatric population. But it's not all black and white. Cuffed tubes are actually much better compared to uncuffed tubes, especially because MRI images of children, they have found that the narrowest portion of the larynx is at the rima glottis. It's not at the cricoid. So all of your airway management plan shouldn't definitely revolve around the cricoid. But comparably, the cricoid is still a smaller circular cartilage. You need to have that at the back of your mind, but that shouldn't be the whole point of your airway management. So in children under 8 years of age, uncuffed ETTs are used traditionally, but cuffed ETTs uh, offer a ton of advantages as compared to uncuffed ETTs. The issue with uncuffed ETTs is that uh, the advantages with the uncuffed ETTs is that they've got a larger diameter, and so it's not about the larger internal diameter. When you're using a cuffed tube, the cuff adds to the outer diameter of the tube. So passing the same size of cuffed tube isn't as easy as passing the same internal diameter uncuffed tube. Always when you plan on changing a cuffed tube for an uncuffed tube, you need to go by zero point 0.5 to 1 millimeters size smaller. So the advantages that an uncuffed tube offers is that you can use larger internal diameter tubes, which eventually offers low resistance of airflow, and then it reduces the work of breathing, especially when weaning a patient off the ventilator. It's always easy to suction, and then the subglottic. But using a cuffed endotracheal tube, the points written above they are very anesthesia oriented. But in an emergency, a cuffed endotracheal tube is the definitive airway. Uncuffed tube is not. So it provides you better protection with respect to the risk of aspiration. And The issue with uncuffed tubes is always that you need multiple intubations so as to arrive at a proper tube size. Using a cuffed tube, by just inflating the cuff, you can ensure adequate seal, and you can avoid multiple laryngoscopies and intubation. And also, if you're planning on monitoring the patient's ventilation, a cuffed tube is more reliable, especially when you're using end-tidal CO2 as a parameter. A cuffed tube is more reliable because there is no loss of tidal volume around the tube. But that loss of tidal volume around the tube is very common with an uncuffed tube. So, why are cuffed endotracheal tubes not very popular in pediatric population? Why the hesitation? So, because it's usually because of the poor design. So, when you use a cuff tube, the distance from the tip of the tube to the cuff, it varies a lot as the manufacturer changes and as the design changes. So, the goal is to, when you using a cuff tube, to prevent subglottic edema, to prevent edema at the level of cricoid. You always ensure that the cuff of the tube is beneath the cricoid. While making sure that the cuff of the tube is beneath the cricoid, usually end up stimulating the carina, hitting the carina, because the tip to cuff length is very variable in various tubes. You might even end up performing an endobronchial intubation. Your tube can be too deep in the trachea. That's second issue is that the outer diameters of the cuff endotracheal tubes varies with the material, with the type of cuff, and with the manufacturer. So, laryngotracheal injury is common when using cuffed endotracheal tubes, but not when actually planned better. And certain factors increase the risk of laryngotracheal injury using cuffed endotracheal tubes, especially if you're performing a traumatic intubation or prolonged duration of intubation, using an oversized tube, or patient's hemodynamics are already compromised during laryngoscopy, the mucosal perfusion is compromised, so that can even result in a worsened laryngotracheal injury, which is basically post-op croup. Sorry if I'm derailing a little to anesthesia, but I'll try to keep it relevant. Lately, we have got micro cuff tubes, which are specially designed cuff tubes for pediatric patients, which has got ultra thin polyurethane cuff with a thickness less than around 10 micrometers, and Murphy's I has been eliminated. The concept behind eliminating the Murphy size is to ensure that the cuff is placed as distally as possible so that the tip to cuff distance is very less. So we have decided on the kind of blade, the positioning of the patient, and the kind of tube you're going to use. How do you decide on the size of the endotracheal tube? So it's always important to prevent airway mucosal injury. A cuffed endotracheal tube should be zero point 0.5 to 1 millimeter smaller than uncuffed endotracheal tube. In children greater than 2 years of age, Cole's formula is used to select the size of an uncuffed endotracheal tube. This is age by 4 plus 4. For a cuffed endotracheal tube, we have got two formulas, actually three formulas. There is another formula called Duracer, which is the same as Motayama. They have done simultaneous work and came up with the same formula. So Kynes goes by age by 4 plus 3. Motayama goes by age by 4 plus 3.5, which is also Duracer's formula. So age by 4 plus 3.5, that is the best formula you can use for a cuffed endotracheal tube. In newborns to infants, internal diameter of 3 millimeters cuffed endotracheal tube, and in children 1 to 2 years of age, internal diameter of 3.5 cuffed endotracheal tube should be used. If you're still worried about causing mucosal injury, and if you have got the patient's radiographs available to scale, not the miniature versions or exaggerated versions, if you've got the x-rays to scale, so you can decide on the size of uncuffed ETT by measuring the tracheal diameter at C7. This has got more success rate than Coles in choosing an appropriate size of uncuffed ETT. So yeah, so many formulas, but if you need a quick look at what tube size do I go for, you can always have reference tables. So you have decided on the tube, you have secured the tube. Now, how do you decide on depth of insertion? The goal is to make sure that the tip of the ETT is located at the midpoint between the carina and the thoracic inlet. That holds true for an uncuffed tube. But if you're using a cuffed tube, please ensure that the cuff is below the cricoid cartilage. So we have got formulas based on weight and age: 10 centimeters for a newborn, 11 for 1 year old, 12 for 2 year old. And after 2 years of age, you have got formulas age by 2 plus 12, weight by 5 plus 12, and internal diameter of ETT into 3. Any of them can be used. And there are certain ETT markers. You can actually palpate and feel for the cuff of cuffed endotracheal tube. But who has got the time to do all the math? I mean, you need to do all the math. Still, you can quickly perform a POCUS, a point of care ultrasound, to understand the depth of insertion of airway devices in pediatric population. You can use POCUS to determine the size of cuffed endotracheal tube to ensure adequate depth of insertion, and the recent concept of TRUST, tracheal rapid ultrasound selling test. This is of immense value in determining adequate depth of insertion, especially in patients who are undergoing cardiopulmonary resuscitation, or in severe state of severe status asthmaticus, has got a pulmonary edema, pulmonary embolism. It's quick. And when you have got factors that are hampering your reliability on end tidal CO2, because in case of a cardiac arrest, ETCO2 depends on the efficacy and on the goodness of your chest compressions. So you don't know how adequate is the depth of insertion. So you can always go for what is called a tracheal rapid ultrasound saline test. It has been tested in age group of less than 18 years. Please do not extrapolate it to adults as of now. So when you have got situations where you cannot rely on ETCO2, a quick focus is the way to go. Take a linear probe, put it horizontally on the neck, and after you have inflated the cuff and bilateral air entry is seen to be okay, deflate the cuff, fill it with saline. Saline filled cuff is better visualized by ultrasound as compared to an air filled cuff, and you'll actually notice the gurgling air bubbles within the cuff. And this is a dynamic test. You can change the depth of insertion as you perform the ultrasound, and they have reported that within 4 seconds we could ensure adequate depth of insertion. We might take some time, but so they came up with that. So trust, that's the new concept. While managing pediatric airways, one emergency management that I would wish everyone knew to manage is laryngospasm. It's a very common occurrence, and if you're standing at the head end of a pediatric patient, please train your team to manage a laryngosspasm, because occurrence of this event doesn't leave any time in your hands. Pediatrics, they have got poor reserves and a very high vagal tone, so they desaturate and end up in cardiac arrest that is preceded by a hypoxia induced bradycardia, and it all just happens in front of your eyes. Adequate preparation is the key. So, what do you understand by laryngosspasm? This is a sudden, sustained closure of the vocal cords to prevent aspiration. It's a reflex, and the reflex always has got an stimulus or a trigger, the efferents, and then the efferents. So, the stimulus is any kind of mechanical, chemical, or thermal supraglottic stimulus. And it goes to the nucleus tractus solitarius, nucleus amicus, and nucleus tractus solitarius, and the efferents are by the recurrent laryngeal nerve that causes sustained adduction of the vocal cords. Some describe it as a focal seizure of adductors of the vocal cords, but that's not really true. And so it is pretty common to for it to occur during intubation and even during extubation. And the clinical signs you can notice when a laryngeal spasm occurs: the patient's efforts to the patient tries to breathe against a closed glottis. Since it's an extrathoracic obstruction, you'll notice inspiratory stridor, paradoxical respiratory movements, suprasternal and supraclavicular retractions, and rapidly decreasing oxygen saturation. When the patient tries to breathe against the closed glottis, they might even end up developing negative pressure pulmonary edema, also called post obstruction pulmonary edema. Many patients end up in cardiac arrest and pulmonary aspiration. So that's the thing. So how do you manage? So this is the closely adducted vocal cords. It's honestly a nightmare to see it happen. So what are the risk factors for laryngospasm? Reactive airway. Any kind of reactive airway, whatever the reason be, the patient is prone for a laryngospasm. Even when you're trying to intubate, the interarytenoid region, the posterior commissure, is very sensitive. Please do not hit on the posterior commissure with your tube. Use a bougie if necessary, but limit the supraglottic stimulus to as minimum as possible. And in trauma patients with active bleeding, there is always a supraglottic stimulus possible that can result in a real bad laryngospasm. How do you manage a laryngospasm? It's important to quickly identify it. And the next step you do is grab a face mask and supplement the patient with oxygen while giving a firm and vigorous jaw thrust, which is known as the Larson's maneuver. And then provide some continuous positive airway pressure with 100% oxygen. You can use a Goodell's airway to relieve the upper airway obstruction, but it can also, if you're using a longer length, larger size Goodell's, it can actually worsen your laryngospasm. It can, because it itself can act as a supraglottic stimulus. The first drug you run to is propofol. At doses as low as 0.25 to 0.8 milligram per kg, usually breaks the spasm. If it is not relieved by that, what you go for is succinylcholine. So you don't have to give the intubating doses of succinylcholine, which is 2 milligram per kg. Doses as low as 0.1 milligram per kg relieves the spasm while maintaining the spontaneous ventilation. The other stimulus for laryngospasm is a distant noxious stimulus. As in, you're performing airway management, you're trying to secure the tube, and someone over there is trying to reduce a fracture in a trauma patient. Any distant noxious stimulus can also trigger a laryngospasm. If the noxious stimulus is identified to be the cause, give the patient some opioids. And it is a newer practice to perform midline compressions, thoracic midline compressions. Mind you, these are not the cardiopulmonary resuscitation compressions. These are just compressions so as to relieve the spasm and open the laryngeal inlet, and also employing the Herring-Brewer deflation reflex. Thoracic midline compressions at a rate of 20 to 25 per minute are known to reverse the spasm. It's not a well-established practice, but you can definitely try it. So if yet the spasm is not relieved, you try to intubate, you couldn't intubate, you can always go for a cricothyrotomy or tracheostomy and have the PALS algorithm at the back of your mind, identify cardiac arrest and act quick. So you're planning on managing a patient's airway. However emergency it might be, a quick airway assessment is the need. So identify the medical surgical factors that brought patient to the emergency, and get a quick history about patient's feeding practices, history of regurgitations, phonation history that will give you an idea about the patient's laryngeal health and laryngeal growth and general appearance of the patient. Pediatrics can have a physiologically difficult airway too. Always optimize patient's hemodynamics, resuscitate before intubation. Next comes the child's facial expressions, understand their work of breathing and drooling. These all point towards certain airway emergencies like epiglottis, where the patient doesn't swallow in response to pain. Identify the stridor, which is basically a high-pitched sound indicative of laryngeal or tracheal obstruction. Identify if it's inspiratory or expiratory so that you get an idea as to if the obstruction is intrathoracic or extrathoracic laryngeal. Have an idea about your patient. Look for syndromic features. Syndromic features, you don't have to actually understand the syndrome in depth. Understand the concerns, understand the aspects that are your own concerns. like a retronathia or mandibular hypoplasia. With certain syndromes, the airway management gets better as the patient grows old, and with certain syndromes, the airway management gets worse as the patient grows old. The discussion is beyond the scope of this lecture, but we can do it later. And in adolescent kids, you always look for loose and deciduous dentation. There are many tools to assess the airway. The ones that are used in adults can be extrapolated for kids, like the lemon assessment using the Malampati grade if the patient is cooperative enough. One score, especially described for pediatric population, is the Copper score. C stands for chin, O for opening, P for previous intubations or OSA, U for uvula, and R for range range of movement. So, Copper score, it can predict the CL grade. Scores above 12 predict difficult intubation, a CL grade of 3 to 4. It's a quick score to perform. So, you've tried to intubate, you've done the assessment, you failed to intubate. So, what now? Emergency access. How do you access the pediatric airway in emergent situations? You have got the surgical and non surgical ways. In surgical ways, it's the last resort in can't intubate, can't ventilate situations. Emergency tracheostomy is the procedure of choice in age less than 6 years of age because identifying cricothyroid membrane, especially in an emergency setting, is difficult. It's too small to be identified. An emergency cricothyroidotomy can still be done if you have got the kits with the 3.546 mmID catheters. Percutaneous needle cricothyrotomy is easy to perform, but you need a transtracheal jet ventilator because it's not a definitive airway. You're leaving a cannula in the trachea. You can't ventilate. You can barely oxygenate the patient. But okay, do I need to stop? So,
Your screen is not visible actually now. I think some audio visual problem is there.
oh, was it visible before that?
It was visible, but the last slide got stuck a little bit.
Can you see it now, sir?
Not yet.
Okay. Can you see my slides now?
Not actually, no.
Okay, let me just check once. Can you see it now, sir?
Yeah, now it's visible.
Okay. The emergency way, the non-surgical ways of gaining an emergency access by sticking to the difficult airway society algorithm is a supraglottic airway. You can use it as a airway device by itself, or you can use it as a conduit for intubation if you have got intubating LMAs like a LMA fast track or a LMA blockbuster. But if the obstruction is glottic or subglottic, supraglottic airways are of no use. What you can go for is a esophageal tracheal combi tube, which is a blind inserted airway device, BIAD. It is contraindicated in pediatric population and very small kids, anyways. And what else can you use is a transtracheal jet ventilator, but it always carries a risk of barotrauma, and it is not adequate ventilation, anyways. So, to conclude, preparedness is very important for our pediatric airway management. PALS, please be through and through with the PALS algorithm. And while dealing with an anticipated difficult airway, please do practice para or apneic oxygenation because
Suchitha, your audio's got stuck actually now.